Absolutely. Yeah.
You've been working on this, I guess, as long as anyone has.
That's just like,
That's always right. You know.
she sets them up, I knock them down.
Yeah, absolutely. Thanks.
Did you,
Sure. Yeah, you want me to, I can speak loud. David Grabowski, Medicare and Medicaid, conflicting incentives for.
Thank you very much. And good luck.
Thank you.
Long-term care. His work has looked at a number of issues which I know will be perfectly synthesized into a compelling and stimulating talk this afternoon, particularly looking at conflicting incentives for long-term care between Medicare and Medicaid. Dr. Grabowski received his undergraduate degree from Duke and then his PhD from the University of Chicago. Spent a brief period of time at the University of Alabama, Birmingham, where he was Dr. Donna Peterson's neighbor. So it's a very, very small world. His work has been extensively published across a number of journals, and if you want to see his vita, you can either download it or see me, and I'm not going to go through all of it, but he's active also as a co-editor of the Journal of Health Services and Outcomes Research Methodology, on the editorial board of journals like Medical Care Research and Review. He's also been the winner of several awards, including the Thompson Prize for Young Investigators from the Association of University Programs in Health Administration. We're going to keep within our time. Dr. Grabowski would like to take questions during his talk, and so I'm very pleased that he's here to share his work and thinking on what is going to be a critically more and more important topic, not just for Florida, but for the rest of the U.S. on long-term care. So, welcome. You figure that out and you talk in this one.
Great. Thanks, Janice. Well, good afternoon. First, thanks to Marion, to Junius for obviously for inviting me down. I'm always excited to come to Florida, especially in February. As you can imagine, it's not quite so warm in Boston. However, I'm particularly excited to give this talk here in Florida because in many ways, just like Florida is the front lines for much of the housing crisis we're currently undergoing in this country, I think Florida is on the front lines for the long-term care crisis that we're going through in this country or about to go through. Florida, obviously, the demographics here are, I don't need to emphasize that with any of you. Clearly, there are Medicaid budgetary issues here. A lot of tensions of late with the feds about funding of the state Medicaid program. Clearly, there's a strong supply of nursing home providers. Many states have gone through a rebalancing, moving away from nursing homes and towards home and community-based services. It's not necessarily clear to me that Florida's done some of this, but not necessarily, it's not necessarily as apparent here as it might be in other states. So I've had a lot of fun talking with everyone. I've learned a lot today over the course of my meetings. We've talked about aging, mental health, more broadly, obviously long-term care and health policy. And hopefully all of those issues will come up over the next 90 minutes, and we'll have a chance to further drill down into some of these issues. As Jeannie has mentioned, the title for my talk today is Medicare and Medicaid, Conflicting Incentives for Long-Term Care. This paper is largely about the silo problem in long-term care. We have Medicare paying for certain services, primary care, post-acute care, acute services, Medicaid paying for long-term care. These silos in payment create silos across providers and setting, which ultimately end up with conflicting provider incentives. So what I'd like to do with my time today is sort of take you through some of these conflicting incentives and then discuss how we might actually go about solving some of these conflicting incentives for long-term care. So before diving in, I just wanted to credit this paper was originally commissioned by the Commonwealth Fund and Academy Health under the Building Bridges, Making a Difference in Long-Term Care initiative. I'm now a co-chair of that initiative since I wrote this paper for Building Bridges. We have 2 meetings a year, one before Academy Health, one earlier this month in February in DC as part of the National Health Policy Conference. This paper was later published in the Milbank Quarterly in 2007. It's actually available for download, no charge on their website. It was one of the featured papers there. And I'm going to sort of take you through some of that paper and also highlight some more recent work that I've published in this area on conflicting incentives. So I'd like to start very generally before sort of moving into the specific example of Medicare and Medicaid tensions for long-term care and kind of give you a setup to think about conflicting incentives across 2 public payers. And I'd like to start out with 2 very general ideas, neither of which hopefully will take a lot of convincing for this group. The first is very obvious. In healthcare in this country, we don't have a single payer system. We have multiple payers within settings and across settings. So for a given nursing home, not everybody is covered by Medicare or Medicaid generally, but some, in most nursing homes in this country, some individuals might be covered by Medicare, some by Medicaid, others might be covered out of pocket or by private insurance. Moving across settings, for a given individual, we also might have multiple payers. For dually eligible individuals, as I just suggested, Medicare might cover certain sets of services, hospital care, post-acute care. Medicaid might cover other services and settings, such as long-term care. So multiple payers both within settings, within a nursing home, for example, and multiple payers for a given individual across settings. The second issue is a little less intuitive, but I also think relatively straightforward. I would argue in healthcare we have commonality in cost both within and across settings. That's commonality in both cost and, of course, in outcomes. The idea here is that when I'm in a nursing home, my care, my outcomes aren't just related to my payer source, but also the payer source of all the patients that surround me. Similarly, as I move across the healthcare system as a dually eligible individual, the care I receive in the hospital is going to influence my costs and outcomes downstream, maybe in a nursing home, for example. And so it's impossible to separate out costs and outcomes in one setting from costs and outcomes in other settings for a given individual. And then within a setting, it's very hard to say that kind of the Medicare side of the nursing home is unrelated to the Medicaid side or vice versa. Obviously, there are some facilities that specialize just in Medicare or Medicaid. But by and large, I think this commonality issue is really important in our healthcare system, both within facilities and within patients. I'm largely, the Milbank Quarterly paper focuses on both within and across setting variation. I'm going to really focus today on just that cost shifting across settings, for really dually eligible individuals. But obviously in the Milbank paper, I also considered this cost shifting within institutions like home health care and nursing homes. But the implications of having multiple payers, having this commonality or interdependence, if you will, is that the actions of one payer are going to impose costs and benefits on services covered by other payers. Decisions by Medicare, for example, influences costs and outcomes for Medicaid, both within and across facilities. And what happens here, and what's so frustrating, I think, as someone interested in health policy, is that neither Medicare or Medicaid fully internalizes the risks or rewards of their actions. There are externalities here, and they're only thinking very narrowly about their own costs and their own outcomes. Sometimes, obviously, Medicare investments will have positive spillovers for Medicaid. Other times, negative outcomes. And this paper is largely about those negative spillovers and how we could better leverage Medicare and Medicaid for the other program. And I think if I was telling you right now that we had 2 private insurers and neither was acting optimally, I'd have a lot of nodding heads. I would argue that public payers, even Medicare and Medicaid, once again, I think I'll probably get a lot of nodding heads in this group. It's a very sophisticated audience, obviously.